Markus Möhler from Germany, and Markus will update us on some controversies in colorectal cancer screening.
Yes, dear colleagues, dear Yola, dear Eric and Florian, thank you very much for the introduction and invitation. I do have only 2 slides for today, and I'm a gastroenterologist working in Mainz, which is very close to Frankfurt. And as you know, there have been many guidelines on screening of colorectal cancer. And in Germany, we just updated the guideline for colorectal cancer. And up to now, in the old situation, we said for the average population, from the age of 50, there is the possibility of the hemocold testing, so the FOBT, or the colonoscopy. And if, of course, there is a polyp, the polypectomy can be done in the same session. And if you do the blood tests or the stool tests, the therapeutic colonoscopy with polypectomy should be done, of course. So in the meantime, however, and this is also particularly driven by the American Society, Cancer Society, the screening will be more or less on a better risk assessment. And here we, particularly the American Society, Cancer Society has established stratification markers for individual definition of risks. And so far in this situation, we have, of course, the typical average patient who has the advantage of having colonoscopy after the age of 50. This is the typical average patient without any risk in the family or with a genetic disease. And then we have the stool tests, and here we have the old GAIAC stool test, but we have also now the immunochemistry FIT testing, immunochemistry testing, which is with a better sensitivity and specificity. And so far there was a discussion about the blood testing, but the blood tests are still not good enough, and there is no approved DNA test so far. And of course, in the US, the virtual colonoscopy has been established, and you may remember that Barack Obama has done in 2010 a colonoscopy by virtual colonography. And since then, there was the discussion, what is the role of the CT-driven colonoscopy? So you are aware that this is only a colonography. It's not, you cannot visualize the polyps and you cannot biopsy the polyps, so it has some disadvantages, and therefore, at least in Europe, it is not recommended as a routine procedure. Again, capsule colonoscopy has some advantages. You don't have to sedate the patients. On the other hand, it is not clear whether this is really cost effective. And with all these tests, I think it's important that we really discuss with the patients what they can have. However, if you look into all the data, the reduction of risk is best done by colonoscopy, of course. So there is a clear, there are clear data that you can reduce the risk for having cancer later is 60 to 80% by colonoscopy and polypectomy. Okay, and the next slide shows the future of colonoscopies, and this is amazing. If you look in the pipeline of all the companies involved in colonoscopies, in the development of of machines, you see colonoscopies with the ability to reflect the endoscope. So this is the retro view colonoscope, or this is with a mirror looking as a third eye backwards. This is a new way for improvement. And then we have new wide view colonoscopes. Here, for example, the Fuse system, which has 3 optics in one endoscope. So you have a screen of with 270 degrees. And there is also another colonoscope with a balloon. And with the balloon, you can inflate the balloon and you see the crypts better than before. However, even if you have all these advantages in the future, at present, it is clear that in patients with high risk, particularly with colitis ulcerative, with inflammatory bowel disease, ulcerative colitis, it is already standard of care that you use dyes, chromoendoscopy to look for the depressed and small cancers. And these are particularly on the right colon side. And this is very often missed. And I draw your attention particularly to this families and patients who are at high risk, and these patients should have chromoendoscopy. Thank you very much.
Questions? So one of the issues is clearly the participation participation and convincing people or having a high participation rate in that. How do you see in the what's the necessary participation rate in screenings programs, and how should that evolve, and how can we stimulate that, Markus?
Recently there has been a nice paper in New England Journal that if the patient population is going for prevention colonoscopy, you can reduce the risk of colon cancer in the whole population. And this is clearly shown now by good studies. And therefore, I fully agree with you. It is important that the average population goes for the screening. Absolutely right. And I hope that also companies or societies like ESMO and gastroenterology societies further support the colonoscopy, of course.
What about the rate of perforation with colonoscopy in the screening program? Because, as you know, it was a real problem to push colonoscopy. And about the acceptance also.
The rate of perforation is very, very low. It's under 1, clearly under 1 per million of dying. So the risk of dying due to perforation is very low, at least for Germany. Before we started the next update of our guideline, there has been a nice paper in gastroenterology looking into that. And the group of Schmiegel clearly showed that the risk of perforation is very, very low in routine
it's 1 for
colonoscopies.
2,000, I guess. 1 for 2,000.
No.
Perforation.
Yes, 1 of 2,000, but the risk of dying is very low.
Can I
Yes,
ask a question, please? Working on the ground across Europe, with great respect, the possibility of scoping citizens for screening is completely unrealistic because it's too costly. And some countries can afford it and some can't. Can I ask the room if there's anybody from a country here that has got a really good success in compliance? And by that I mean over 50%, because you hold the secret to compliance, and that I would love to know. Regarding screening, full stop, yeah. So there isn't anybody.
I mean, even if the population does not do colonoscopy, you have a clear benefit also of FOBT. So the normal testing by stool tests is also efficient. This has been shown. The reduction for cancer risk is lower, however.
Yes, but the issue is indeed the participation, Markus. And if you look at the quality measures that are being brought forward, that's the EU has written, and I had the privilege to participate to that, a whole booklet with recommendations of 300 pages recommendations how we can implement screening and for quality control and so on. And one of the issues is participation, and that's and with FITs, with the immunological FOBT, you can obtain probably participation degrees of 50 to 60% of the population that receives this. With colonoscopy, as far as I'm correctly informed, there was one region where they did a systematic also goal in Europe for screening colonoscopy, and the participation was 5%. You can say if we do that every year, and then you multiply that by 10, then you come up to a participation of 50%, but that's probably not the correct calculation, because you will not have every year cumulative. So that's the issue, and that's why the colonoscopy, I agree that it's the best test, but it goes against the health policies in Europe, which in all countries, and there are now, the European Commissioner updated us on Wednesday during a lunch at the European Parliament. There are now 17 countries in Europe who have an official installed screening program, all with immunological or the classical Gouillac testing. So that's the health policy in Europe, and that's different with the US. So it's interesting, these developments of the new techniques, but I don't see that happening in the near future for population screening. For individual approach and individual screening, if you go to your doctor and you say, I'm worried because my sister had colon cancer, then you should do a colonoscopy. But that's individual screening, that's not population screening.
I fully agree, yeah.
Theo from the Netherlands. I don't know what the background of your question was. Was it the adherence to the colonoscopy program or the adherence to the population screening by fecal occult blood test? Because in the Netherlands...
Adherence to screening, full stop.
Okay, the adherence to screening in the Netherlands, we just started, but we had 2 pilot areas with the fecal occult blood test. And in these 2 pilot areas, the adherence was over 70%.
And I'm sorry, which country are you from?
Netherlands.
Pardon?
Netherlands.
I know you've had a very successful program. Yeah.
That was in the pilot program.
That was
in the general
pilot.
country.
Yeah, we just
will
started, but
probably
the pilot
between
program,
50 and 60%.
Yeah, but the pilot program in Amsterdam and Rotterdam was quite okay, actually. It was over 70.
And you're going with FIT? You're using FIT or FOBT?
Yes, of course,
the FIT is the immunological
We are using the
FOBT.
immunological test.
The immunological. That already is much easier because it's one test. Trying to get people to do 3 tests with FOBT, plus after that repeating it every 2 years is a big challenge. So I think with the immunological testing it will be easier. I'm very sorry, but I'm going to have to move us on to the next speaker, and maybe we can pick up this debate at the end.
Thank you very much.